short. So, Peter, the floor is yours.
Lovely on Baldis par uzaicinājumu. Okay, I've got very little time to tell you about something that I've been trying to do for the last 18 years or so, since I first discovered that some women have very specific deep dyspareunia patterns. It's a problem because when you look it up in the textbooks, there's almost nothing there. And although everybody knows that women with endometriosis suffer really severe pain in some positions, perhaps not others, nobody has defined exactly what these positions are. Here are my declarations. I've got no conflicts of interest with this particular presentation, but I have to declare that this is the very first time I'm presenting this rather old data now as an oral presentation, but it's previously been a poster at the Royal College of Obstetricians and Gynecologists World Conference in London a couple of years ago. So if we actually look at perhaps arguably the best review of all the qualitative research that's done. Remember, this has to be qualitative. It's what the women are telling you. You have to listen to women's stories. It's very difficult to quantify this. You have to just think of how each individual woman experiences the pain that they get. It's a very good review coming from the unit in Milan, and it looks at the various different publications, many different publications that there have been, looking at the perceptions of dyspareunia, how the women suffer themselves, their psychological impact, not just the physical pain, how it affects their intimate relationships, and how they cope. And there are a number of different ways that people cope. They can give up altogether, have non-penetrative sex, choose their partners wisely perhaps, and maybe that doesn't make much difference. Think about sex toys. But I'm interested here in this thing at the bottom here, because if you look at all the gynecology textbooks and all the research, there is not a single study that looks at positional dyspareunia or defines it. And I have to ask the big question, why is it that nobody has asked this question? Is it because they're afraid to ask the question, or maybe they ask the question but they don't actually write it down, or they don't do it in a systematic way? Another question is, how did I get the idea to do it in the first place? Well, it was a personal experience. I think I've learned almost all I know about women's health from being taught by women or listening to women, and I was very lucky to have a girlfriend who had a pelvic clearance for severe endometriosis very shortly before I met her. And she commented that for the first time in her life she was able to do some positions that she could never do before because they were too painful. And this piqued my interest because I've been doing pelvic pain clinics for years. So in my clinical setting, 2 different clinics in different towns nearby, I looked at 18 months worth of patients, followed prospectively and retrospectively. And what we did was very, very simply ask them lots of different questions about what type of pain they were getting and what positions they could and could not have sex in. And in this clinic, there were 149 women seen during that time, and we excluded other dermatological conditions such as localized provoked vasculodynia, or treated it with estrogen, and that was why the first time I came to Riga was that particular presentation. So we excluded all of those cases, and about half of the women had clinical symptoms that were strongly suggestive of endometriosis. Now, we excluded 8 of those women because we tested them all for anticlimateal antibody, and some of them were raised above more than or equal to 512 theta, which is synonymous, if you like, or more as pathognomonic of PID. Of course, they could have PID and endometriosis, so we took them out of the analysis and ended up with 70 women. Now, these symptoms we turned into a dysmenorrhea symptom score, which we tried to call the Bristol endometriosis score, but it didn't work. But there were some successes. So obviously these women had to have severe dysmenorrhea, which was bad enough to keep them off school, sport or work, and they all used painkillers and heat treatments, mostly in the UK, the hot water bottle. And I invented the sign HWB positive for the hot water bottle sign. And many of them were using hot water bottles to the extent that they actually burned their abdomen. So we're talking about women with very severe pain. Also, many, but not all of these women got better when they had been taking hormonal contraception. So we call these women who possibly had endometriosis. If we then add in menstrual dysesthesia, which is pathognomonic of deep infiltrating endometriosis, or tampon insertion pain, and then to top it all, the family history of endometriosis, or other family members with the same symptoms but not yet diagnosed with endometriosis, we call that probable. And to test this, I asked my local surgical gynecologists to review all the patients that I had sent them, and we put the cases together. These were all women who presented as if they had pelvic infection but had low chlamydial antibody titers. And eventually we found that approximately 5 out of 6 were correctly diagnosed by the symptom score. So that's the test that we used. So what questions did we ask? We ended up with 70 women, of whom 25 were possibles and 45 were probables. In others had menstrual dysesthesia or family history, or indeed both. So first of all, we actually asked what type of sexual positions they had tried. Now, of course, trying to define what is one position or another, because the Kama Sutra has many more than the 12 or so positions that are here, and we had to actually find a way of standardizing this, which I'll tell you in a moment. But we particularly asked whether they'd had deep pain as primary dyspareunia or secondary, whether it was nil or mild, in other words, they could avoid the pain and intercourse, penetrative intercourse was possible, or whether the pain was moderate or severe and therefore unavoidable, and they perhaps might have tried that position once and had so much pain that they would never do it again. And we also we openly asked them for any other details they wanted to fill in. Now remember, this is very, very heteronormative or hetero-focused penis in vagina sex. It's not the only type of sex, as we actually heard earlier on from Marie, rather better than I could have time to describe. But that was the focus of this particular study and what we wanted to try and get into, something that might be useful for the gynecology textbooks. So we defined 5 principal positions, and I'm sure you have different words for these positions in your own language, and we decided to work out which positions were most painful and which positions were least painful, or least commonly causing pain. So if we look at the whole chart, these are the patients grouped into possibles and probables, with a total of 70 women altogether. And 73% of the entire group had primary deep dyspareunia, and interestingly, only 10% had no significant dyspareunia. Interestingly, the 2 women who had probable endometriosis and had no dyspareunia were very tall, more than 1.80 meters. And the taller you are, apparently, the longer the vagina, so they would have needed a longer man to reach the parts that others couldn't. And luckily, they escaped pain. And I know for a fact that 3 of the 5 women in the possible group didn't have endometriosis but had adenomyosis. So that's another possibility. So looking at one of the most painful positions, it's the on-top position, the woman sitting on top facing, or the so-called reverse cowgirl, either of those positions. And in this particular case, I'm just showing you this little box here that shows not everybody had tried those positions, but of the 49 who tried it, of the 57 who had tried it, 86% had significant deep pain. And that's the figure there. So if we do the same for the doggy style position, the rear entry position, the figure was 81%. Not everybody had tried that position. For the missionary position, everybody had tried that, and the results were mixed. A lot depended on the skill of the partner, the size of the partner, we're talking length, not girth, of course, and also the skill of the couple and the exact position of the legs and a number of other features. So that was a variable situation, but still most of those women got severe, moderate or severe pain, bad enough for them not to want to do that position. But very interestingly, in both the spoons and the so-called male Astride position, where the man puts his legs outside and the woman's legs are together, those are positions where there's no penetration deep into the posterior fornix, and none of the women had any pain. Of course, not everybody had tried those positions. So what are our main findings? That a very large proportion of women with presumed endometriosis, and remember these are not necessarily proven, presumed endometriosis have primary dyspareunia, and think of the damage that that does when they're starting their sexual career. 1 minute, okay, nearly there. And 10% had no dyspareunia. Interesting, something we haven't mentioned before, for menstrual dysesthesia is very strongly predictive of severe dyspareunia, 27 out of 28. And unavoidable dyspareunia was in 5 out of 6 for the on-top position, 4 out of 5 for the doggy position, and the male on-top was 2 out of 3. So the textbook conclusion is written here, and you can read that for yourself. That's what would be nice to see that in the textbook. Also, it'd be also nice to see it in the guidelines, because it's not actually actual positional dyspareunia isn't mentioned. Dyspareunia itself is mentioned, but the actual positions aren't mentioned. So what are the take-home messages and advice? Obviously, you need to educate yourself and your partner or partners. Get onto a cycle suppressive contraceptive regime and prioritise the full repertoire of non-penetrative sex. And perhaps the best thing you can do is to choose a female partner, because you're much more likely to get satisfaction. However, you could get out the chocolate spread and the strawberry jam and find a man who knows how to use his tongue. Also, very useful if you have a man with long arms. Remember, in the spoon's position, you don't get any clitoral stimulation, so you either have to do it yourself or find a man with long arms. But perhaps most important, it's important to get a man with a short penis like our friend. So that's more or less it. I'll just leave you with a couple of other thoughts as to where we're going with this. So if you are heterosexual and you want penetrative sex, then first of all you have to define your own trigger point. So feel in the back wall of the vagina to find where the pain starts, and know that that's as far as you can go. Think about doing slow motion sex, which is as if you're a slow motion action replay, that you do all the sex from the moment you go into the bedroom as if it's in slow motion. It's comedy, it's pure comedy. You'll fall about laughing, and you might actually enjoy it. And guess what? It'll last longer because it's slower. Also, obviously, you can reduce the depth of penetration with the O-nuts or other types of things, so pillows either side. I'm going to finish now. Last thought. So I invite you to recommend the spoons and the male Astride positions. But finally, my last bit of advice to male doctors, particularly take-home message for male doctors, is to let women do the talking, to ask and then listen to what they... listening is the best way to learn what they like and what they want, and then give them what they want. Thank you very much. It's